Hey everyone, welcome to another session of Virtual Global Spine Conference. It's my honor to introduce a colleague and friend, Sanjay Konakondla. He currently is a spine-focused neurosurgeon at Geisinger Health System, where he does residency training, and we actually share the same fellowship, having been trained under Zia Gokaslan and Albert Telpian at Brown University several years ago. So we're all really excited to have you here, Sanjay. And why don't you go ahead and give us a whirl on endoscopic applications for thoracic spine pathologies?
Awesome. Thanks a lot. Good evening, everyone. Thanks, Mike, for the invite. Thanks for tuning in. As Mike said, I'm one of the spine guys here at Geisinger. I help run the endoscopic spine program here. And over the past few years, we've had a lot of exciting developments, and it's really transformed our endoscopic spine practice and our spine practice in general. So I look forward to some good discussions here. So we'll talk about how to apply the endoscope to the thoracic spine. These are my disclosures, nothing really pertinent to this talk. Just a glimpse of sort of the arc of this talk. Feel free to interrupt me as we go. I have a few cases here, and I think if I go, I can probably talk for a very long time for this. So if anything comes up, feel free to tune in at any time or chime in at any time. So we'll talk about the basics of the thoracic spine disc herniations. We'll learn how to apply those basic principles to other spine thoracic processes, and we'll touch upon some of the future applications of where that's going. Just some quick hits on some obvious facts on thoracic spine, thoracic disc herniations, which we probably all know. It's depending on what you read, it's probably going to be 0.4 to 4% of thoracic disc of all spine herniations. We'll call it less than 1% here. They can come in all shapes and sizes, soft or calcified. Most of them are actually calcified, maybe up to 65% of them. They can be small, central, asymptomatic, all the way to large and giant with severe myelopathy or radiculopathy. And really what we operate on is really progressive symptoms and severe myelopathy, or just bad radiculopathy that hasn't responded to medical management. And again, as we all know, the goal there is to preserve function, resolve pain, and give the best chance of functional recovery, all while avoiding spinal cord manipulation. And there's, really a ton of options on how we accomplish that, right? And really the end point is the same. Posterior laminectomies, transpedicular costotransversectomies, lateral extracavitary, all MIS or open. Of course, the transthoracic with or without a scope, and of course the endoscopic applications with interlaminar, which is primarily going to be for the dorsal pathologies like a hypertrophy of ligamentum flavum, or the transforaminal approaches, a little asterisk there because it's technically modified approaches depending on the pathology, because you're going to be drilling some of the IAP, some of the SAP, maybe some pedicle drilling, and really tailoring it to the patient. But obviously there's no current standard for that yet, and each approach really has its own place. So, when we're considering these types of procedures, we really have to talk about, we have to think about what visualization we're going to have, what limitations we're going to have, what issues we're hoping to avoid, what complications we may have, and how to fix those, right? Anywhere from durotomies, especially in this area when we're talking about intrathoracic negative pressures, which can be pretty difficult to manage, spinal cord injuries, the amount of bony resection we have to do to accomplish our real goal of a particular surgery, all the way down to institutional resources, right? What help do we have, and how we're going to manage post-operative pain depending on what type of procedure we choose. And it's not real different for endoscopic thoracic disc resections. All those considerations are the same. So here's some overall points for the indications of thoracic disc herniations. They're going to be the same. The steps, just like any other case, planning, I feel like, is always going to be the most important, especially when you're dealing with a thoracic spine, and especially with endoscopic procedures. And then targeting is typical. You mark your trajectory, and this will go into a little bit more detail as we talk about the cases. But you identify your anatomy, you find your joint, you figure out what bone you need to take off. Once you remove the SAP, you're really in the epidural space. Sometimes you don't even need to get into the epidural space if the pathology is extraforaminal or intraforaminal. The obvious pros to endoscopic, less collateral damage, as we all know, less bone and facet resection, the off-axis view with angled scopes are key. It helps us to get, within millimeters of the pathology, helps us look and peek around corners. All the benefits of continuous irrigation we can talk about for the next hour, but technically, or basically speaking, it's going to help us dissect tissue, help with hemostasis, visualization, and it helps us sort of protect neural elements and so on. Avoiding scar tissue is also helpful in folks that have had posterior approaches before, because we're not going in the traditional trajectories. It does have a steep learning curve, especially when we're talking about dealing with the spinal cord and the cervical or the thoracic spine. It's not the thecal sac that has the cauda equina nerve roots, it's the spinal cord behind the dura. So, you can't plunge, there's little room for error, and your reach may be limited depending on the pathology and your trajectory. And again, we'll go over some specifics on why that may be so. Wrong level surgery is always going to be an issue for spine surgery, and it's going to be even more so an issue with thoracic spine surgeries, but probably even more of a consideration for endoscopic, because nothing's attached to the table, right? Anything that's in the surgery that you're using, whether it's the scope or the tubular retractor, everything's moving. So millimeters of change at the skin level could put you at a completely different level. And we'll talk about ways to sort of mitigate those issues. All these notes we'll talk about for the rest of the talk during the cases. So we'll jump right into it. The first case is a 57-year-old female. Her really own complaint was radiculopathy. You talk to her, she just can't stop talking about this left-sided pain that sort of matches up to this T910 level. But objectively speaking, when we do the exam, she's having severe myelopathy, right? She can't walk, she's holding on to things, which interestingly enough, she wasn't complaining about. So folks were telling her, you have this bad pain, doing a big surgery on this is not worth it. And, it really, if she was truly only having radiculopathy, maybe optimizing her medically would be the only route there for her, depending on what your goals of that surgery was. But you can clearly see this big, T910 disc there pushing against this cord. Of course, the only picture of the axial that would show it has a bunch of this artifact, but you can see there, maybe even some of that disc there. You always get a CT. Again, up to 65% of these can be calcified. And it's not just enough to know whether it's calcified or not. We have to get a little bit nuanced in that, especially when we're going in there with a small port and a small camera with tiny instruments, right? The area of calcification is important, right? Is it central or paracentral? In this case, it's sort of more favorable towards the left side. And it's mainly in the disc, right? There's no rim of calcification going around like this. It has some implications of the maneuverability that you'll have in working around those areas. The heterogeneity is important because it's going to suggest how this is going to feel when you get in there. In this case, it's going to be sort of like a stale cookie-like consistency because of these spotted calcifications, dispersed throughout the disc. The disc spaces, in this case, can be calcified. In this case, it is. That's going to be important in also identifying your level. So you can see that and identify that sometimes in your intraoperative fluoroscopy. This is how the OR setup looks, at least for my cases. It's very similar to any transforaminal case, even in the lumbar spine. In general, you just want to have the screens opposite from you so you can see them. And you're always working on the side of the pathology for most of the cases, and you want your assistant and everyone sort of on your same side. So, these are some sort of key pictures. Note this spinal needle here. I put a spinal needle to have at least one static instrument to denote the level once we're done counting, because that's the only instrument that's not moving throughout the case. So I like to have that sort of as a home base to remind ourselves that we're at that disc level that we need to be at. And also, again, keeping in mind with the preoperative pictures, you can see that intradiscal calcification there. So that helps us sort of reconfirm where we are. That's the 3.5 millimeter round diamond drill bit going through the SAP. And again, once we get through the SAP, we're in the epidural space. We can pass curved ball tips to sort of confirm that we're above and below the disc space. And that helps us a lot. fluoroscopic images helps us to see how medial we are. And if the disc is paracentral or extraforaminal, we don't need to get this far, but depending on your pathology, you really want to be sort of goal oriented, just with any other surgery, really. So just some key images here. If cranial is to the left and caudal's to the right, this is really your SAP coming down, or your IAP coming down, your SAP coming up, and the joint space is really easily identified, and that's really nicely reproducible there. And typically you don't have to take off any or a lot of the IAP depending on where your pathology is again. But right behind this SAP will be the epidural space. So you remove that, and this is sort of how you keep oriented throughout the case. And this way, whether you have intraoperative navigation or fluoroscopy or intraoperative CT, you can use, many ways to sort of confirm what you're looking at. Obviously, as an exercise, you like to predict what you're looking at before you take any picture, because that's sort of, using it as a confirmatory test rather than learning throughout the case. So, after you drill out the SAP, you start seeing some spaces, right? Epidural space here, spinal cord behind some remaining SAP here, and you see this disc herniation. Okay, nothing unexpected, no surprises there. As we remove the disc herniation, we start seeing more space ventral to the spinal cord. So the spinal cord's really going sort of at a 11 to 3 o'clock trajectory there. Disc herniation starting to get resected, starting to see space ventral to the thecal sac there. And as we remove more bone or more bone and more disc, we get more space in front of the spinal cord. Again, same orientation, that's where it is. And here's a small video. That's us with a small pituitary grasper taking out that, again, stale cookie-like consistency disc with some of that calcification in there. And once you remove that calcified disc, we're starting to see a nice space ventral to the spinal cord there. So that's how you know you're done, and you take your confirmatory pictures above and below the disc, and it's very satisfying to see. So, just a reminder, that's how it looked pre-op, and this is the actual picture post-op. I had to sort of check and make sure that was the same patient, because it sort of looks like we weren't there. But clearly you can see on the axial imaging, that's our trajectory, that's our collateral damage, sort of taking maybe a little less than a third of that ipsilateral facet, sort of reaching this way and getting to that disc. These are, as you know, how the incisions look for those endoscopic cases, but we're able to discharge her home the same day. She didn't need any narcotic medications. Her myelopathy improved, and most importantly for her radiculopathy improved. So very, very exciting to see these sort of results. Another similar case with some, nuanced challenges is this 32-year-old with a BMI of 54 who had, again, severe myelopathy, and, no kidding, because of this large, again, T9-10 disc. And it's, not only a large disc, but it's also, caudally migrated with some significant implications there. You can see it's taking out maybe about 35% of the canal there and displacing that spinal cord towards that left side and dorsally. So, again, always do a CT, and this is what you find. The scout images are there because it sort of gives us an idea of the challenges of any type of thoracic approach to this disc, whether it's lateral or, transthoracic or transpedicular or anything. But, we tried to do this endoscopically. So clearly all calcified, and it's just not okay to say it's calcified. It has this calcified rim. And also, if we translate this laterally, the pedicle's here, right? So it's probably in this orientation. So it's behind the pedicle. So, these are some important considerations to make before you get into it, because if you do a typical transforaminal approach, you're only seeing this area and you're never going to see that. If that was a soft disc, that's okay, because you can always reach around. But in this case, obviously, it's not going to be possible because of that hard rock. So we digitally reconstructed that, but we also reconstructed or subtracted the planned bony resection with this. So we're able to see, yeah, we have to take out that SAP, we have to take out the IAP, and probably a little bit or a good amount of this T10 pedicle there to get a good visualization of that, that green disc there. So we printed that, again, with the bony subtraction, the SAP, TP, and pedicle of T10, but also the T9 IAP. And that's what we're hoping to see when we stick the scope in there. And these are the key intraoperative pictures of the case. I always do these markings on the patient, midline, and the level of interest, but also the trajectories. So we get the needle in there, and you can see it's not a transforaminal or typical transforaminal trajectory. This is the SAP going up. This is the pedicle. So we're docking sort of lateral to that pedicle, because if we continue in that trajectory, we're going to get to that caudally migrated big disc that's sitting right there. And this is a nice picture to look at, because you can see this drill sort of at the medial border of this ipsilateral pedicle. And then once we're drilling through this with this thoracic pedicle, which is about 80 to 70% of cancellous bone, as we know, this drill sort of eats through that. You can see the cancellous bone in this video as we're drilling through. But as we identify cortical structures, we know that after the cortical rim of bone, we're going to be either in the disc or the epidural space. So that's a nice way to find out how you're close. And again, you identify that on the actual image of your endoscope, but then you confirm that again with your intraoperative fluoroscopy. So, this is the same disc, and this is sort of, as we're getting done removing the disc herniation, this is where most of the pedicle was. This is the caudally migrated fragment now removed. And now this is the last remaining fragment towards the head. That's really, as you can see, folding this spinal cord in half. So as we remove this last remaining disc fragment, you can see sort of this cylindrical spinal cord, sort of assuming its natural morphology. This was published in JNS as a neurosurgical focus video, so anyone interested could sort of see that video. We were doing post-operative MRIs earlier on, just to sort of have a proof of concept, just to sort of see what we're doing there. And it's helpful to know what we're seeing in surgery, and sort of correlating it to what it translated to an MRI is, I think, helpful, especially when we're learning what we're able to do with this. Pre-op MRI, big disc again. Most of it is gone with good decompression of that spinal cord. Again, you can see the collateral damage here, the trajectory essentially. Again, staying out of the intrathoracic cavity and no real rib resection at all. And of course, a nice incision. So she got much better. Her walking improved and progressed from a walker to a cane, and is continually improving up to a year. So, this is what the practice turns into eventually. These folks start showing up out of the woodwork. We talk about 0.4 or less than 1% of all disc herniations, but this is a good amount of my practice. And all shapes and sizes, multi-level, or soft discs, giant discs, or multi-level thoracic calcified discs. So it's exciting to tackle these pathologies with applying some of these basic principles with the endoscope. So just looking back in the last 24 months, this is some of the data we quickly pulled together. Most of these discs are in the lower thoracic spine, which really matches up to the current literature, right? It's like T8 to T12, or where most of these discs occur. Most of them are going home the same day. Even more of them are going home the next day, up to 92% of them. Most of them have myelopathy, some with radiculopathy. We try not to prescribe narcotics to most of these people. If they ask, we give it to them. Zero complications. We did bring 2 patients back about a year or so after the surgery because they had progressive myelopathic issues after initial improvement. Repeat MRI demonstrated discs reherniation. So we just approached those from a contralateral approach, and those went well. 92 of those patients improved neurologically immediately post-op. 1 patient did not, due to some psychological issues and some secondary gain, but she proved to have complete neurologic recovery after a couple months. 1 patient required instrumented fixation because we did a circumferential decompression there. And again, none of them required a chest tube, or approach surgeon, lung manipulation, all minimal blood loss. And I do, for now, all of them under general anesthesia. So, we put together some of the characteristics that are important from what we learned from these cases: disc characteristics and patient characteristics, right? So size of the disc, location of the disc, is it paracentral? Is it easy to get to, or do we have to do a bit of reaching to get to the central areas? Again, calcified and not calcified is just a part of that story. Caudal or cranial fragments for, dictating extra bone work is important to keep in mind. Patient characteristics, BMI is important, but level of pathology. Do we have to, if we're dealing with high thoracic spine pathologies, do we have to consider the scapula? Costovertebral joints are important as we go up to mid thoracic and higher thoracic spine areas, because the rib can get in the way of your transforaminal approach and the disc space. Morphology of the ribs is an important one that I didn't think was important earlier on, because you want to avoid getting into the intrathoracic cavity. If the apex of the rib is here, but you want to take a more shallow trajectory to get to your pathology, it's going to be tough, because you have to avoid getting into the chest while coming in shallow at the disc space. So sometimes you're really limited on the morphology of the rib, because this is really your trajectory you can take if you want to avoid getting into the thoracic cavity, and you can't get any more lateral and come more shallow. So those are important considerations to make preoperatively, so you don't realize those issues intraoperatively. So, you can't miss shallow, or you should miss shallow. You shouldn't miss deep, right? So if you're targeting with your needle, you want to make these errors, right? Anything here is fine, especially if you're taking your intraoperative fluoroscopy and you're not using intraoperative navigation. If you're too medial but superficial, this is good. It's fine. You're in muscle and you're against bone. But you never want to miss deep, because you're in some bad areas that you sometimes can have bad complications from. If you're reaching
question.
Go ahead.
Sorry to interrupt you. Is there any particular type of a disc that really is too much of a reach for this endoscopic approach? When you just showed kind of a variety of different disc herniations, calcified, non-calcified, that you've taken care of over the last couple of years or so, I mean, some of them look like really nasty cases, and presuming you did all of them endoscopically. So is there anything that you would feel is really too dangerous for the endoscope? Maybe if it's bilateral, or some of these ones that also have some element of calcification of ligamentum flavum, facet hypertrophy in combination with the thoracic disc herniation. So I'm just curious what your thoughts are about that topic.
Yeah, it's all valid questions, right? And if it's all ventral pathologies, and if it's soft, clearly it's, you can get that with a endoscopic approach. If it's all ventral and it's calcified but paracentral or extraforaminal, great. If it's central calcified but the patient's only complaining of radiculopathy, maybe you can offer them an endoscopic procedure to clear out that foramen and help them with their picture clinically without having a goal of resecting the whole disc. So I think it really can be tailored. You make those considerations as you go. If it's broad base and you really need a complete discectomy there, then you consider bilateral. I truly believe in good hands. It's still a half step, right? If we try an endoscopic procedure and we say, hey, this is too complex to take out while we're in there, we're still able to offer them any other procedure they would have gotten anyway. So, from a safety perspective, if you're operating within your limits and you talk about those expectations with the patient, live, and you make those decisions together, I think that's probably the best way to deal with that. We're not doing anything here where, we're going outside of our bounds, trying to get cute while putting the patient in danger. And I think that obviously that's always going to be the consideration there.
We do have a couple of other questions from the chat box.
Yeah.
Robert Bailey is asking if you would mind telling us the specific scope and retractors that you use. And Dr. Matthew Barachek is asking if you could just comment on what happens if you encounter a durotomy during one of these operations.
The first question I use Joymax. I mean, I feel like at this point, all scopes are really the same, depending on what you learned with, and they all have their own, instruments that we're all used to using, graspers and pituitaries and nerve hooks and things like this. The scope here is the traditional scope that we use for our transforaminal lumbar approaches. And the port is the same as well. It's a 30-degree angled scope, so we're sort of peeking around corners with that too. I think the intralaminar scopes are 15 degrees, but I think we need a little bit more when we're dealing with those. Durotomies, I haven't had a durotomy yet, but I do have a case where we talk about a repair of a ventral CSF leak, which is a spontaneous CSF leak. We can do that just like we do any other scope repair, is with packing. If I did have it in plans for that, I would probably locate the area of the dural opening. An inlay gel foam has really been advocated for in the endoscopic community, and then either fat graft, muscle graft plus a dural substitute plus glue is probably a good combination to help with that. So sort of, along the same lines here, we're putting together a patient candidacy framework on those principles, right? So, patient characteristics, disc characteristics, what's easy, what's not, what deserves a further discussion. So we're trying to figure out what's the easiest thoracic disc to start on. And that's probably going to be one of the lower level, not calcified symptoms that you're only trying to solve with radiculopathy, and not a big disc and a disc location that's not really central, with a low BMI. And that's probably a good starter endoscopic thoracic disc. But I think all these, like you said, and like you correctly pointed out, they're worth a discussion. But, at the very least, I think a discussion. So, we'll jump right to the other pathologies, right? So, we talk about targeting and getting to those areas, identifying the pathology or identifying the bony anatomy, and then dealing with the pathologies. Dorsal ligamentum flavum is another one. If you're having only dorsal pathology, yeah, you can do that with the endoscope and dorsally decompress that, but that's not really, the challenge there with thoracic cases. That's just a laminectomy and removing the dorsal pathology. So we have cases of infection, thoracic tumors, and CSF leaks and fistulas. So this is another case, a 42-year-old female, 3 years of headache. She was diagnosed with intracranial hypertension. She was treated multiple times with empiric blood patches, which worked, but temporarily. She found us in our clinic through reference. And you can see the MRI showing sort of this extradural CSF. Typically the challenge with these cases is not treating it, but actually identifying them, right? So we're able to sort of pinpoint this area of leak from, via a prone CT myelogram. And you can see this ventral leak here, right by a small bony spicule there. Tiny, but important. We talk to the patient. Alternatives for this is obviously going to be your dorsal approach, laminectomy, intradural approach, retract and cut the dentate ligaments, turn the cord around and fix this primarily, fix that ventral dural defect primarily, which we could always do, or we can offer the endoscopic approach, try it, see if it works, because again, that to me, that's that half step, and we could still always offer that intradural open approach anyway. So that's what we did. Docking into that area is the same way we dock for any disc. We're getting ventral to the spinal cord through that modified transforaminal approach. And again, that's our drill, going through that SAP. Once we get to the SAP, we're going to find the cord there, and we're going to be ventral to that. Again, that's our spinal needle there, keeping us true to that level of pathology. So here are some key images from that case. We get in there, we take out the SAP, we identify the spinal cord. And, surprisingly, it's, this disc ossified complex is a little bit more exaggerated than that was suggested on the CT. The way I'm able to identify that is, once we identify the disc space, we like to follow this river of disc space centrally, because here's the superior end plate and here's the inferior end plate. And when we follow that, if it follows this line, anything from here up is going to be a herniation. It's going to be outside of that that area of disc space between the vertebral bodies. So whatever's higher than that, we're thinking shouldn't be there. So, and we can always see this bowing of the spinal cord there. So we remove that disc ossified complex and we're able to see some space now, right? So this is the PLL, and we're able to advance this curved ball tip ventral to the spinal cord contralaterally across that parallel to that disc space, dorsal to the disc space. So, here you can see the dura, sort of redundant laxity of dura here, because likely this extradural CSF. But since we've isolated a nice space ventral to this dura, we can now pack this, right? So we stick some gel foam in there, we take a nerve hook, and after having some fat and muscle graft, we also stick that in there. We cut a piece of dural substitute, also stick that in there, and then squirt some dural sealant on top of that. So, we're very satisfied with that closure endoscopically. It's always tough to get small pieces in there under the continuous irrigation. So we found stopping that irrigation temporarily, putting the material into a place you want to get it to, and then resuming the irrigation for visualization was a nice nuanced technique we did there for that. And she did well, right? We again, small incision, getting to this area ventral to the sac and the high thoracic spine. Again, this was T2, T3. We didn't have to have any real interaction with the scapula there. We got kind of lucky. After a year, she's had 75% improvement of her headaches, right? She's able to sort of bend down, look underneath tables and chairs and things like that, which she wasn't able to before. So she's very satisfied for now from that procedure. So, partners are texting now, and this is sort of a frequent thing. There's something in the thoracic spine. Can you reach it with a scope? And the answer is we can try, right? And this is obviously advanced osteodiscitis there. Failed multiple rounds of antibiotics, and ID was advocating for washing this out and maybe potentially getting some new cultures there. So this is a quick video of getting down to the disc space, pituitary graspers, identifying the disc space through your fluoroscopy again to confirm, opening the annulus, and this is a bipolar device. You can use it as a dissector sometimes to get into these areas. And once you take this out, you can see the sort of purulent material expressing itself from the disc, which was nice to see. And, the advantage of having this continuous irrigation is that there's antibiotic in this fluid, right? So we're continually washing this out as we're expressing this fluid. We take some graspers in that disc space and really clean out a lot of that phlegmon. So, we're able to drop a drain in there as well, and keep it in there for a few days.
Sanjay, another question from the chat box.
Sure.
Dr. Barachek again was asking if the pressure of the inflow in thoracic cases and how it compares to your lumbar cases. I think he's talking in reference to the irrigation.
Yeah. So, there's some studies coming out. I think the last one I read was a few months back about the issues and complications of irrigation. I think it was primarily due to the lumbar spine. They were talking about increased incidence of seizures from this. It's tough to say. I don't make any particular changes to the type of irrigation that I do for thoracic versus lumbar cases. I think for me, typically, I think for the stateside, actually, the flow regulation and the pressure regulation, we keep our numbers on the lower end. So we don't see a lot of issues from that. So, we use our same settings that we do for lumbar spine and the thoracic spine because they're not as high as some folks, and we don't feel like it needs to be. It's an easier picture when you're having a higher, obviously more pressurized fluid, but clearly, as suggested by the question, there can be some issues with that. But there's a setting, there's pressure and flow regulation in most of the irrigation systems. Now for the endoscope, I usually have my setting at 30 to 40. I don't really raise it that much. And it really, again, depends on what bed you're using, the position of the patient, how high the bags are compared to where your hands are and where the scopes are. So that has a lot of implications, where the heart is based on the blood pressure. But I think the thing that I just keep in mind is just don't take it too high, but I don't put it high, close to high. So I don't really have those nuanced changes to thoracic versus lumbar.
Hello, Sanjay. May I ask you, this is Alexander from Switzerland. May I ask you a question? Are you also get the calls from lumbar spinal infections to use a scope for washing out a disc and infectious disc, or do you only get the calls for thoracic?
I ignore the calls for the infections, actually. It's not fun to apply it just to apply it, right? I think there has to be some reason to try these approaches for it. In this case, if we tried to approach this surgically, it'll be a much larger incision for, bony resection and asking a lot for a patient to heal when they're trying to cure an infection. It's frequent where we get these calls, but for lumbar pathologies, it's really primarily for the epidural components, and really those are the phlegmon type materials, and they're not just like a pus-filled pocket that we can easily drain. I think honestly, even those are handled a little bit better through our interventional partners because they're able to get to these places easier as well. So I think those calls are happening less for lumbar because they're easier to get to for other folks too. So, if we ask them to put a drain in the lumbar, in a lumbar disc, I think that's easier to do. This is a 60-year-old female, metastatic breast cancer. She had upper thoracic pain, and imaging showed a T3 pathologic compression deformity with spinal cord compression. This is us getting into that disc space. I'll slow that video down. So just to orient this is sort of the orientation there. This is the remaining portion of the SAP there. As we play this video, you'll start seeing pulsations in this area. It's always nice to identify the epidural space in that manner. We can see epidural fat, and behind that remaining piece of bone and fragments, you can see some of the spinal cord, or the dirt around the spinal cord. All this, as we play the video, is the remaining portion of that ventral tumor. And essentially what we're doing is working in this area. So we're going to see this ventral portion of the tumor. We took the drill and sort of drilled around this area. So you'll see that deeper hole around 4 to 6 o'clock in this video. So we'll bring that back.
Sanjay, what's your workflow here? Obviously, I'm assuming you're placing instrumentation at least 1 or 2 levels above and below. So are you doing like perc fixation and then endoscopic approach? Is that how you go about doing this?
So sometimes with folks with poor bony quality, I feel like sometimes putting in the instrumentation can wash out sort of our bony identifiers. So I'll drop in K-wires just to, again, have those static placement markers there for our levels. Then you don't have to think about if you're at the right level. Obviously, with a compression fracture, you're seeing it throughout the case. But yeah, from a workflow perspective, I'm dropping in wires, and then I'll go the transforaminal approach here. And then I'll do most of the, if not, as much as the ventral component as I can. And if we need to do dorsal work, I have no problem doing a small midline incision, doing dorsal work, and then finishing off the screws, because, really, yeah, you can get the ventral component freed through the endoscope, which is great. But what we're really trying to accomplish is making room circumferentially around the spinal cord. So, if you decompress the spinal cord, that's one goal, but making room for that radiation, as you know, is going to be important. So, I'll drop the K wires in, do the endoscopic work, and then do more posterior work if I have to. And that saves me sneaking around the cord and really passing along like Woodsons and things from the back, which is simple enough to do, but I like to get a lot of the anterior work done through the scope. The important thing to note here on these finely curated videos is you don't see the extensive bleeding from these tumors, right? I mean, the breast can be a bloody tumor, but it's not one of the bloodiest, but they can get pretty bloody. And you're working with this tiny bipolar, and it's a lot of exchanging of equipment. You're in there, you take out a piece, it starts bleeding, your continuous irrigation is there, you find the bleeder, you coagulate it. Sometimes even with these tumors, it's tough to even coagulate it. So you have to be prepared to open these, and these you have a discussion. Yeah, let's try to get most of this through the scope. And if we can't, then we always have the option to open, and that's going to be a possibility. And again, it's going to be the approach that they're going to get anyway. So let's play this video. So this is actually a nice shot to look at. Try to ignore my lines that I drew in the previous picture, but remaining portion of the SAP, spinal cord, and all this tumor here. This hole is the partial corpectomy that we were able to do with the drill. And this, this is not, trivial. We're drilling, we're taking out the drill, we're bipolaring, we're putting the drill back, we're drilling a little bit more, putting the bipolar in and bipolaring. And it's a process to get that work done. And, it's clearly, I would say a lot easier and maybe even a little bit more efficient at this point, even now, to do this open, where you're having two hands in there, big, robust instruments, and really getting a lot of work done, and taking the tumor out faster so it bleeds less. I think especially with the applications of spinal oncology, as we all know, this is probably not to the point where this is going to be standard of care anytime soon. There's going to be a lot of developments here, but I think it's an interesting application if you want to avoid, sneaking around the spinal cord from the dorsal approach, and in really getting some work done with some good visualization. So there's us working there, and you're going to see this bipolar. We use it as a dissector as well, getting into that space and really just peeling away that tumor from the spinal cord. You pull that down, you take graspers, and that's your ventral work is done. So in general, for us in lumbar or thoracic or cervical, and like we already alluded to, I like the half step of endoscopic, because in elective cases, we get to offer them this endoscopic approach. And if not, we could always fall back, right, to all the procedures that we've gotten anyway. We don't really lose much. And if we're able to accomplish it and stop there, that's great. I honestly view this sort of closer to injections, just like we try injections. Hey, we send patients for injections, and if it helps, then great. Then you can try another injection. If it doesn't, you can still try another injection. And if it doesn't work, then at least we have this next half step to offer. And I sort of like that workflow. It's obviously a team effort, right? This is not a one person show, and everywhere from looking at the capital expenditures and trying to minimize OpEx and really writing business plans and all the boring background stuff that goes into building an endoscopic practice. It really takes a robust team and a tremendous effort. So, and that's the team. You talk about the future of endoscopic spine surgery. The question of who's the perfect patient for an endoscopic spine procedure. You can't ask that anymore. The indications are growing rapidly when you're talking about open or MIS cases and the overlap there. And especially when you're looking at these thoracic cases, The applications are growing. In fact, with thoracic pathologies, I would say, you should try to see if there's an option for these thoracic pathologies to get treated with the endoscope, because you're avoiding these sort of larger procedures. With VR and AR robotics, intraoperative navigation, et cetera, I think endoscopic is right there in the mix. Especially in Western culture, there's a lot of industry engagement now, because we're adding the big F word to endoscopic, right? You're talking about those endoscopic fusions. So there's some incentive there, especially when you're talking about reimbursement. So, lots of exciting things, obviously, for the future, and definitely more to come for that. And that's us peeling off that last final cortical rim of that large calcified disc there. This is just a dissector that we can put through there, and you can see that dura sort of pulsating after removing that last remaining fragment. That's a view ventral to the dura, and that nice disc space there, remaining portions of that vertebral body on the top. So, this is clearly a topic that's really near and dear to me, especially when we're talking about thoracic applications for, spinal oncology and giant disc herniations, and, always enjoy talking about it. Feel free to reach out, and happy to chat. Thanks for listening.
Sanjay, that was absolutely fantastic. I think what you're doing it's very transformative for the field of spine surgery, because if you think of the way we were all trained to take out thoracic discs, it was probably either via a transthoracic, retropleural, or a posterior transfacet or transpedicular approach. These are big, long, morbid approaches, and you're taking, what would be a 6-hour surgery with tremendous risk to the patient, possibly a chest tube, prolonged hospital stay. And now you have the skills to take this down to a maybe a 90-minute, 2-hour operation, and they're going home within 2 hours of surgery. And so I think what you're doing, and some of the other leaders in endoscopy, is very transformative for the field of surgery, even for spinal oncology as well. I mean, we always talk about how we're doing things less invasively. In my own practice now, for separation surgery, I may place perc screws, mini open approach. I mean, you're taking it to the next level, though. You're putting an endoscoping, you're still being able to, obtain a separation type surgery without even really opening up the patient, which is incredible. My personal question to you is, if you could just maybe touch upon your learning curve. Obviously, we have somewhat similar training backgrounds. We both trained at Brown. We both trained with Zia. You probably spent a lot more time with Albert than I did, and I kind of regret that in retrospect, having seen what we were able to achieve here. But can you just kind of take us through your learning curve in your first 3 to 4 years in practice, and how you've gotten to this skill level now?
Yeah, I mean, first of all, thanks a lot, and I appreciate that. It's very, very kind words, and it's just exciting to sort of challenge yourself every day, and that's part of it. And you alluded to it. The going to Zia Gokassan's fellowship, and taking advantage of, sort of the other side of the spectrum that's right across the hall, which is Albert Telfian, sort of using smaller things to get to the very similar areas that we're used to getting with Zia. That's the catalyst there. For the learning curve for me primarily was the business aspect of it, honestly, because coming into an institution and not having any of the equipment there was probably the hardest part. Again, writing the business plan and sort of, getting everyone together for a movement of folks. I mean, there's always going to be skepticism in the beginning too. We had multiple meetings where people just think, oh, this is just this fancy thing. We've been there, done that. And, and the endoscopic, especially in the Americas, have, it struggled to take off earlier on because of the lack of technology and the poor visualization, et cetera. So there were some hurdles there. But once we got, the equipment and started, doing a number of cases in the lumbar spine, I think that's where it starts. When you start going to these endoscopic, I don't think there's a number. of cases you need to do before you can, progress yourself to the next level. I personally think everyone's individualized from a surgeon perspective, but the number you're hearing a lot, obviously, in these conferences are, somewhere around 50 to 75 lumbar cases before you progress to thoracic and endoscopic cases. But as we know, and we're all in academic institutions as well, everyone learns differently, everyone applies themselves differently, and everyone has their own interests, right? So I think doing a little bit more and more each case is going to be the key there. Again, there's always going to be a case where it's going to be your first thoracic endoscopic case, right? And I think an important part of that is involving the patients in those decisions, because it's really something, at least for us in our institution, that it's something new that we're trying here. So being super candid and truthful and transparent to patients, I think, is part of that, because you're learning with them. And I think knowing that you have the ability to do it open, or the quote unquote traditional way, is comforting. So, trying that within your own limits is going to be, and being reasonable with it, I think, is a way to go about it.
Yes, Sanjay, I think you mentioned the most important topics, being transparent and being open in a discussion with the patient, that you can't offer a technique which is 20 years old and which is worldwide proven. And this is, endoscopic surgery is somehow a teacher-free technology here in Switzerland. Yeah, there are not many doing these, and where you can go and learn from them. So you are really a pioneer, and it's really interesting to see worldwide that this technique is evolving and pioneers are going to the limits. And 10 years ago, when there was a tumor, and I said, maybe it is a small incision, and my teachers told me, no, tumor is not a small incision. You have to have a big exposure. You can control the bleeding better. And now you're talking about oncology patients and a resection and corpectomy via endoscope, and it's really amazing. And I'm really glad that you are showing us your technique and its experience, because we don't have the teachers here.
Thank you so much. And I think, when we look at this worldwide, and, especially going just in the Global Spine Conference just a few months ago, it's interesting to see the trajectory of the endoscopic applications in the spine in different parts of the world. It's really fascinating. Some folks who find biportal very traditional and very easy to use, versus uniportal techniques, whether it's thoracic or people doing anterior cervical surgeries with the scope. It's always exciting to learn off of everyone's experiences.
And the other side, what you mentioned, is that you you have to have a business plan. You have to convince the administration to invest hundreds, thousands of dollars for the equipment. Yeah. And you have no teachers, but you have a lot of critics, people who criticize you, even if they haven't witnessed any endoscopic surgery. And the next thing you mentioned is how important it is to have a team where you can do the open ones, because if you implement a technology outside in private practice and something goes wrong, you will leave this technology forever. You will not do a second case again. Yes. So it's so good that the big institutions, the big hospitals are going for this technique.
It's tough because, you try not to overpromise. When you lobby for, this huge capital purchase and you're the only guy using it, you've got this microscope on you to make sure your outcomes are okay and you're doing good work. So it gets a little bit nerve-wracking sometimes to sort of deliver on that, but I guess it's all part of the experience.
Sanjay, do you see any applications for intradural pathology at all with the endoscope?
Is it possible? Yes. Do we have to do it, or is there a reason to do it? I'm not sure yet. And that's, again, super subjective. That's my opinion. I saw some, intradural schwannomas that, looked super favorable, but then you think, what are you really gaining with that? And again, I could be convinced, but I haven't been convinced yet. Can you do it? Yeah, but I don't think the instruments are refined to get a nice, eloquent surgery out of it with a scope. I don't think it's there yet.
All right, Sanjay. Well, I think that just about wraps it up. We're almost to the hour. We all really appreciate you giving this wonderful talk tonight. It's going to be posted on YouTube in several days. And next week, it sounds like Ali Baj will be hosting Karen Edmondson. She's the publishing manager with Theme Medical Publishers, and she'll be discussing the current and future trends with spine textbook publication. So I'll hope to see everyone there next week. And again, Sanjay, thanks so much. That was absolutely fantastic. Hope you all have a good rest of the day.
Thanks so much, guys. Have a good night.
All right, take care.